So essential thrombocythemia comes with that thrombotic risk, and we have patients that need to control the blood cell count, so-called high-risk patients. And in this setting, once we decide to engage a patient with what we say cytoreductive therapy, typically we would use a hydroxyurea. It's a chemotherapy by mouth, and it's pretty effective in about 3/4 of the patients, but not in all. And then what do we do in every practice if it's not working? We use a second-line agent called Anagrelide. It's a medication that is another pill, inhibits the growth of the cells in the bone marrow called megakaryocytes that make platelets. But we learned that there are other benefits when we start therapy with this cytoreductive therapy in ET patients. It's not only about controlling the platelets. We also want to control the high white cell count, which may be present in some patients, and control the symptoms, and control the spleen if it's enlarged. So we have actually 5 factors to go about. And we also have a knowledge about use of interferon as a therapy for patients with ET, but no interferon has ever been approved. So what you are talking about is the study that we are very happy to have, where we compare a new interferon preparation called Ropeginterferon, which is being compared in the randomized phase 3 study to Anagrelide in patients with ET that failed or resistant refractory to hydroxyurea in order to control the platelets and the white cells. So it's a global study for possible approval of interferon, first time ever, as a therapy for ET, for a second-line patients, comparing it, and hopefully it's going to be better than standard practice Anagrelide.